Hello, ladies and gentlemen, dear colleagues. Today we'll go on with the next lecture about the principles of MRI and the specialities in the diagnostics of implants and how to look plastics, flaps, things like this. And let me start with my title. Okay. So I would like about aesthetic interventions, allergenic flaps and implants in MRI. This, I think it's a new thematic we have to deal with. And what we have to know is what are the types of flaps. One type is a latissimus dorsi flap, when the muscle from the back part is used to be filled the breast volume. And if we look to T1 weighted imaging, we can see things like filling of the lateral parts of the breast with this latissimus flap. This is a very fresh new flap, so you can see the muscles that are very intermediate type of signal. We have other filling situation when the whole breast is filled with this latissimus flap from dorsal. And there are also combinations of latissimus flaps with an implant, so it's a combination of both. And you can see on the right side, this is a situation when we look to an older latissimus flap, we have something like lipomatous degeneration, and there are only some remaining muscle parts seen on this T1 weighted imaging. Next, we have the TRAM flap that's coming from the abdominal structures, and the flap is used to fill up the volume of the breast, and the vascularization is still the same than before. The surgeon will put this flap from the abdominal part into the breast subcutaneous. This is called the transverse rectus abdominis mucocutaneous flap. And what we see on MRI is, again, T1 weighted imaging. This is a pure lipomatous flap, and there are no non-lipomatous parts within the breast. And on the right side is the fascicutaneous flap with the anastomosis to the mammaria arteria. No, it's no anastomosis, it's directly coming from the origin. So if we use contrast material, we have to be careful that we don't misinterpret this feeding artery to the flap. It's coming from the abdominal parts. Sometimes it's easier, like this situation. It's clear that these are vessels. However, sometimes we have something that looks like a nodule, and you can think about is a tumor or something like this with an enhancement. And as I told, we have to be careful to see this is a feeding artery for this TRAM flap. Even the breast is removed, we know that there is a possibility to get a tumor relapse in case of breast cancer before. And so this is a situation after a mastectomy of the left breast due to a breast cancer and TRAM flap. There was a little tumor relapse. And if you see things like this, this should be very suspicious, and we have to clear the situation by ultrasound or mammography or percutaneous biopsy. And moreover, we have a differential diagnosis in cases with tumor relapse or breast cancer. You see the situation after the application of contrast material. there is mass close to the implant with strong enhancement, and if we look to the T1 pre-contrast image, we see this is free of sickness, so this is an enhancement of proliferation structure on the one side, and if you look to a similar constellation in the same breast close to the implant, we see something like a very small rim enhancement. This is T1 weighted, a structure filled with fat tissue or oil. This is a fat necrosis with reactive hyperemia in the periphery. And so we have to differentiate between malignant tumor on the one hand and normal findings, benign findings on the other hand. We talk about deep flap. Deep means this is an inferior epigastric perforator flap, and this we'll find the anastomosing artery that is feeding this flap, but this artery and these veins have been cutted, and this flap needs an anastomosis to the arteria mammaria and the vena mammaria that he can feed it after he has placed into the breast. So you can see this tissue can be taken from the abdominal structures as before, as the other TRAM flap, but in this deep situation, we have no persisting feeding artery. This feeding artery has been cutted, and it has been made an anastomosis to the mammaria vessels, as you can see here. This is the situation in a deep flap reconstruction. The tissue can be taken from other parts of the body, as the gluteal region, or the inner parts of the upper leg. All these flaps became separate names or terminology. So I think it's not so important for us as a radiologist to know all these things. We have to know what's the appearance of a deep flap in imaging. And let me show, this is the situation before. This is a bilateral deep flap. You can see that mostly fat tissue was used, and to bring the volume into the breast, sometimes with the origin subcutaneous fat tissue, sometimes very close to the skin. And sometimes they will give this flap more stabilization by using a mesh. And you see this mesh on T1 weighted imaging, even in the upper and lower slices. You can see this structure of the mesh, and you can see also the mesh if you make mammography in the periphery of the flap, again, just for stabilization. There are other ways to get an increase of the volume of the breast. Sometimes they will use lipomatous tissue and make something like a lipo or lipo-filling. This can be done into the pectoral muscle, as you can see here. So T1 weighted, we have a high signal from the fat tissue in the breast and also from the fat cells in the pectoral muscle. This is T2 fat saturated imaging, and the fat saturation of the lipo-filling is much more than the fat saturation in this normal fat tissue that has a higher content of water than the lipo-filling will have. If the lipo-filling becomes older, you see on this mammogram there will be something like a capsule is building in the periphery, and there is also the possibility of building out macro calcifications to enclose this filling area. Other types of, no, let me say I'm one before. This is also Lipo-Filling, and this time the Lipo-Filling was done in the subcutaneous fat tissue to correct some aesthetic aspects or things like this. This is a very old situation, even though you can see in mammogram that there is a calcification in the surrounding, and to enclose this depot of fat tissue, and there is no significant enhancement after the application of contrast material. So this is filling up of the breast with lipomatous tissue. You can also use hyaluronate injection in this situation. Again, it was injected into the pectoral muscle on both sides, and moreover, there are smaller injections in the close to the nipple of the breast to get a better aesthetic result. If we use contrast material for looking for enhancement, you see this situation is clean, is free of enhancement, and so it's inert. There's no reaction from the body to this hyaluronate injection. You can use it, or it's used also in the periphery of implants, as you can see behind the nipple of the breast and in the inner parts of the breast. Even in this situation, there's no enhancement. There's no reaction to this filling. This is another situation if you use silicone for injection. This was a free injection of silicone with so much silicone bubbles in both breasts. And also this has been many years before, and the reaction of the body, we see this macrocalcifications, all the small depots of silicon are enclosed, and with the shell of calcifications, even some silicon in the lymph node went the same way. And if you use ultrasound, you see this hypoechoic changes. This is not the image of silicon. We expect something like snowstorm effects or something like this. So this is the imaging of the calcifications in all localizations. And even MRI will show this situation. You have silicon, and the silicon suppressed imaging. You see the lymph nodes are filled with silicon. In this silicon, in this silicon sensitive measurement, we have a little bit of reactive hyperemia. This is let me say, after the injection of silicon, there is a chronic inflammatory process in the breast all over the life if it's free silicon. Okay, I make a cut and I will talk about breast implants and give some information about implants before. We have to know that there are different contents in the implants. We have, this is a modern type of implant filled with silicone gel with fixed aerosphere, so it make it not so heavy, and textured surface. In this case, we have implant filled with saline, round. This is an older type, a round implant filled with saline, and we have also double lumen implants, or very often these are expander implants that can be filled by using this port system. And there are two components within this implant. One aspect is silicon, that's a fixed aspect, and the other aspect is saline, and saline will be filled over this system. So if silicon is in the middle and saline is in the surrounding, we talk about an inverse type. and in the other way, also types are possible, and on the market we talk about reverse type of double lumen implants. This is a situation, sagittal imaging T1 weighted. You see the end of this port system within the saline component, and this is the silicon component, and you can follow this this tube to go outside at the back side of the implant. So you can see here this tube ends within the inner component of the implant, and this is the let me say the adapter to fill up this inner component. And if the breast has the size you wish, they will remove this whole system. They will take it away, and the backside of this implant will be closed automatically. So if you use expander systems that are very, very ferromagnetic, so the port systems with metal ferromagnetic structure substance, you will get an extinction due to susceptibility, and if it's pure metal, this extinction can be complete for the whole breast, so there's no more possibility to get a good information about the left breast in this case. We have double lumen implants as well as single lumen implants. Most implants actually are single lumen implants and look like this. This is a normal demonstration of single lumen implant with T2 measurement. This is double lumen implant on both sides. You can see the ventile in the background, as I told before, and you can see the two compartments filled with saline and filled with silicon. The localization, usually the implant will be localized within back in the muscle, the pectoral muscle. So this is a subpectoral localization of the implant. Sometimes you will find a subglandular or subcutaneous positioning of the implants. This is up to the surgeon. How about the terminology of the implants? So we talk about the shell. This is made in the factory. This is made of silicon, and after the placement, after the implantation, more and more you will find these folds, and they are, let me say, angulated. They are spicae usually, and filled with body fluid, with seroma between the shell of the implant and this capsule that is built by the body within 6 to 8 weeks. And there is sometimes as a little bit seroma between the capsule and the shell, or within these radial folds. But there shouldn't be any silicon. Silicon is inside, and outside the shell there is no silicon. It looks in a single slice like this. You see the silicon inside, and on the T2 weighted fat suppressed imaging, and you see this seroma of water-like serum signal within the radial folds. Can look to a T2 mid presentation. All 50 single slices can be seen in one image, and you see this radial folds filled with serum, and the content of the implant is silicon. How about the protocols? We use a special protocols to look for complications of implants. So one protocol we talked so much about was the protocol to detect breast cancer. We have to use T1 weighted gradient echo sequences with contrast material once before and 1-2 times after contrast material. We need a high temporal resolution to find even the small breast cancer. And for a better detection, we use image subtraction. This is the breast cancer protocol. So what we use for implants is another protocol. We use T1, okay. T2 imaging preferred with fat suppression. And in addition, we can perform silicon plus and silicon minus. This means this is, I will show you later, the peak of silicon can be closed or can be opened. We have all the time of the world for the implants because there is no necessity to give any contrast material, and therefore we will get a high spatial resolution. That's very important, and we should use a wide windowing to get information about the content within the implant where we have the silicon. Moreover, as we have all the time of the world, we can perform axial sequences as well as sagittal views. So all in all, if we look to the carcinoma protocol, takes about 10 minutes, and the silicon protocol, implant protocol, this takes a longer time. We have all in all about 40 minutes measurement time for this combi protocol if we use it together. The other way is to perform this breast cancer detection protocol on one day and the implant complication protocol on another day. So this is what I told you about. The first sequence we use is sequence when we get a high signal intensity in the area of water and in the area of silicon, but we do not want to see the fat peak, so we make a suppression of the fat signal, and as well as water and silicon, they both will become signal intense. Next, we can make a suppression of the fat peak plus the water peak. So this is silicon sensitive or silicon plus. You see only silicon will make this high signal intensity. All other structures become dark. And on the other way, we can make something like a suppression of fat tissue plus silicon, and only the water component or the serum component will make the signal so intense like here. And we will get an information about the content of these radial folds if they are containing something like water, serum, or something like silicon. So this is what we do in this special silicon implant protocol.